Aldosterone escape, however, is a chink in the armor of the ACE inhibitors, and this was first described by Bertram Pitt, who you see here, and this was in 1995 when he published a paper called Escape of Aldosterone Production in Patients with Left Ventricular Dysfunction, Treated with Angiotensin Enzyme Inhibitors, Implications for Therapy. Now, the term aldosterone escape has been fallen into some disfavor because it was really taken by physiologists some years ago to describe a physiological parameter, and so most people now prefer the term breakthrough, which is what we will use. The work that came from this then, 4 years later, the RAAS trial, which everyone here is aware of, but it truly is a major breakthrough in our understanding of the management of cardiac disease and failure. And in this trial, in a double-blind placebo-controlled trial, spironolactone, a very inexpensive, old-fashioned drug, was compared with using standard therapy to standard therapy with a placebo. So, and to the surprise of almost everyone, maybe except Bertram Pitt and maybe even him, this study had to be stopped early, not because it was failing, but because it was doing such a good job that it was unethical to continue. So there's about a 30% reduction in all-cause mortality by the addition of spironolactone. So the idea then was that if you added something else that blocked the mineralocorticoid receptors, you got better survival, meant that there must be something to do with this escape phenomenon that Dr. Pitt described. The idea of escape occurs when one looks at the fact that things other than angiotensin converting enzyme can cause this conversion. So chymase is one that in the tissue is known to do this, and when this happens, then it does not need ACE, and so ACE is blocked, then you still may get production of aldosterone. Potassium elevations will cause secretion of aldosterone, and then ACTH or cortisol will also cause release of this mineralocorticoid from the adrenal gland in heart failure states or states of stress. Then this will increase the amount that is produced. Aldosterone then affects mineralocorticoid receptors in the kidney, heart, vessels, and brain. And 2 or 3 of these are important to us as cardiologists. So how does this happen? Well, one of them is chymase, as I've mentioned. That's a way that it can bypass the system that we know best and we have the ability to block. So there are many theories. It's clearly not well understood. Aldosterone breakthrough then occurs with ACE inhibitors and angiotensin II receptor blockers, but we know that these things cause beneficial effects in patients with cardiovascular disease, heart failure, or hypertension. ACE inhibitors work, but do we have a chance to make them work better by covering over the chink in the armor that's associated with aldosterone escape? The circulating RAAS is what we're able to look at clinically because we can look at it in blood and urine. And we do know now that RAAS inhibition with these drugs is not always complete and it's not always permanent. Aldosterone is elevated in a subset of ACE inhibitor-treated heart failure patients. And in people, you'll see that the data is surprisingly sparse, but this will make up about 50% of heart failure-treated patients when they receive an ACE inhibitor or ARB. And it's important to realize is that the clinical outcome in these patients is worse. This is a meta-analysis by Andrew Bombach, published in 2007, and they started off with 190 citations which covered some aspect of aldosterone escape or breakthrough. But when they threw out those that were not in humans, when they throw out those that did not give the values in the paper, et cetera, they ended up with approximately 500 patients. So this was a 40-some-year period of time in which they looked into the literature, and they came up with 500 patients, about 10 a year. What Dr. Bombach found was that breakthrough appears to be neither dosage nor agent related. So that would cover then all the ACE inhibitors, and it would cover ARBs as well. The reduction in cardiac mass was seen only those without breakthrough. So some of the beneficial effects to the heart in terms of reverse remodeling were lost in those patients that had aldosterone breakthrough. So this shows you the definition. So definition 1, the more lenient one says that an ACE inhibitor is given, plasma aldosterone falls, and then it rises, and once it comes back above the baseline value, that's defined as aldosterone escape. The second definition used a specific value, and this was done, these were varied. They weren't all the same in the different papers, in those 6 papers. Some said they needed to be over 80 picograms per ml, and that's the one I chose here. Another one said over 160. The point is that it's come down, presumably, and then bounced to some level that's not appropriate for an animal on some ACE suppressive drug. This is the possible way that this can go. You start to administer an ACE inhibitor, and the red dashed line shows you that it falls down by 80%. So aldosterone levels fall, and they stay down. And that makes up about 50% of the patients. Alternatively, they may come down and then fairly quickly come back up to produce harmful effects. They may stay down for a longer period of time and come up and cause harmful effects. Or there are some, and you're going to see from our experimental data, that some that never seem to suppress at all. And this group, aldosterone breakthrough or escape, occurs then in approximately half the people.